Okay guys, so the topic for today is going to be looking at B12 and differentiating between a serum versus a functional perspective on this. And the reason I wanted to go into more detail with you on this topic is because this is something that I get a lot of questions from other clinicians about. I hear things from patients about this. Patients are coming in with B12 markers and we're looking at labs, and labs don't exactly, some of the functional stuff doesn't exactly correlate. So what I wanted to do is give you some background on the whole story of B12, what are its functional roles, and then with that in mind, how do you really go about getting an accurate measurement on it? And like I did last time, I'm going to intermingle in some visuals here for you, and I'm going to also back that up with some of the literature references, so you'll have all of that information to make a valid case. And I think once we get done with this, you'll really see what the state of B12 assessment is and what you need to be doing clinically. So just a little bit of quick background here. I know most of us know this, but it bears repeating here. So the actual scientific name on B12 is going to be cobalamin. And I just want to refresh that in your mind because that's going to be relevant to some of the different assessment methods that we're going to look at here. It's water soluble, so it's pretty much like all your other B vitamins there. And then it's going to be animal derived, and then your different functions. And really, when we're looking at these different functions, the reason I'm bringing these up for you are these are going to be different testing assessment methods is what we're going to be thinking about here. So you're going to be looking at red blood cell formation. That's actually where we'll start our conversation at. You'll also look at your DNA synthesis, fatty acid metabolism, specifically things like that myelin sheath around the axons, trying to make sure that you've got that good insulation to get healthy neurotransmission. Looking at brain function, your homocysteine regulation. We'll get into a lot of detail about that, and then detoxification. So just even looking at impairment of, we said we're going to talk about hormones next time. Looking at impairment of being able to eliminate hormones in the body could be simply related to a B12 deficiency. This diagram that I've got up here is actually the biochemical structure of B12. Seems a lot more complex when you look at it in that format. It's just kind of how we typically throw it around on a day-to-day basis, saying B12. What I wanted to point out to you in looking at this structure is I want you to see all the different methyl groups on here. I'm just going to kind of shoot through them real quick. Methyl group, here. You guys can see all these different methyl groups in there, right? Okay, that's significant for B12. Now, the reason that that's significant is all of those different categories that I went through with you on the previous slide. This methylation process, the ability of these to donate these methyl groups is really what allows B12 to have a role in every one of those different physiological functions that we talked about on the last slide. And it's really just the process of taking that CH3 group and donating it somewhere, sending it to another molecule. Now we talk a lot about homocysteine from a laboratory perspective. And I wanted to give you a little bit more insight into this pathway so we can kind of biochemically start to think about what it is actually that B12 is doing in the body when we talk about these different, whether it's red blood cell formation, detoxification, whatever process it is we're going to be looking at. And actually what you'll notice here is that this is homocysteine, and to get from homocysteine up to methionine, you've got to be able to have efficiency in an enzyme called methionine synthase. And that's methionine synthase is a B12 dependent enzyme. So B12 is actually part of that enzyme system. And then you guys are familiar with looking at the folate cycle, the MTFHR. You've heard about that from looking at it from a genetic perspective. But really what this boils down to is that you've got to have B12 as part of this, and then you've got to have the completion of the folate to come in to get from homocysteine to methionine. And this is why it's so important for us to look at homocysteine and seeing if homocysteine is backing up in the tissues, in the serum, because if it is, then it really begins to give us information about what the status of this cycle is and what's inhibiting this homocysteine from either moving up to methionine or moving down to glutathione eventually. So just wanted to use that particular slide. that's probably about as in depth as we're going to get today on the actual biochemical pathways. But this is a good one. If you're going to look at a biochemical pathway to memorize and commit to memory, this is an excellent one to have committed in memory. Now, what I want to point out with this too is that why are we even bothering with B12? Why do we talk to our patients about it? Why is it so relevant apart from just the biochemistry here? Well, look at what this study says. Vitamin D is emerging as a growing public health problem. So, if you really start kind of reading through this body of literature, the overall theme is that B12, what we used to think about as far as B12 being a problem in society, like really how much deficiency was out there, we know that it's far greater than that now. And what we're recognizing is that the testing methods that we had to pick this stuff up really weren't accurate, and there's a better way to go about doing this. So if you just think about it, and actually most of you in here are looking at the micronutrient testing. Without question, B12 is one of the most common nutrients that pops up on that test, right? Mm-hmm. So what we're finding on those tests is actually mimicking what the researchers are saying in the literature now. We'll actually come back and revisit this study again for another reason. When you're looking at different ways to assess B12 status, the real question you should be asking here is, does my method of assessment reflect methylation? If it doesn't, it's really not getting to the bottom of what B12 status is in the body. It's really not telling you what the utilization of B12 is. Because as we all know, there's certainly a difference between availability and utilization, right? We want to know what the utilization is. And I've got some diagrams for you as we get to the back end of this presentation that are actually going to illustrate this from a cellular level to really help kind of solidify this for you. So let's just take each one of these particular areas, and there's more than this too, which I'll touch on as we go forward as well, but these are the big ones that we have direct access to, or that are readily available for us. So looking at red blood cell size. So what we're looking at here is when you take these red blood cells and we break them down and we look at them in more detail on a complete blood count, on those CBCs, is there a way to differentiate whether we're going from these naive stem cells down into these proerythroblasts all the way down to a good, healthy, functional erythrocyte, right? Good, healthy, functional red blood cell. And what we know in this process is that as those red blood cells are maturing, this is how I explain this to patients. They work inverse of the way we do. We start out as infants, and the older we get, the bigger we get. Right? Red blood cells do the exact opposite. They start out very large, and the more mature they become, they decrease in size. Right? So that's where you start looking at that MCV marker on your CBCs, that mean corpuscular volume. It's that volume we're concerned about. So if the absolute volume of these cells is staying too large, it must mean that these cells are not maturating as fully as they should be. Now, let me go to the next slide, which is this exact same scenario presented in a little bit different manner. And here's what happens. Notice in this where you start with a stem cell, and you'll notice that the size on this continually decreases as we go from left to right. What you're going to see here is just before we get into the actual markers that we can pick up on the CBC, these reticulocytes and the red blood cells, you're going to notice that the maturing red blood cell actually kicks the nucleus out, right? So this nucleus is where you actually have DNA methylation taking place. So if this cell, because of inadequate maturation from deficiencies in B12 and potentially folate here too, but if it doesn't maturate and shrink down to a certain enough size by the time it kicks that nucleus out, then you've got a cell that's too large, and that's what's represented on the what's represented by the MCV value on those CBCs. Okay. So inherently, you can look at this and go, well, I know my red blood cells have to maturate to a certain size to have competent B12 and folate status. And here's just a look under the microscope to really give you an idea of what this looks like in real world and actually in the blood. And what you're going to see is these large cells. These are actually going to be your megaloblasts, macrocytes, however you guys want to say that. and then this is going to be your normal healthy red blood cell right here. Pretty noticeable difference. So what is it you're actually looking for on the blood count with these? So that MCV value, the normal standard clinical ranges on this are going to be about 80 to 100. Like we've talked about before, really doesn't give you a functional picture on this. Pretty wide range in there. So what we want to do is we want to look from about 85 to 92. And generally what I'll see with this is that patients are either really good and they're sitting right on 90, or they're at 92 and above. Rarely do you catch them in that 91, 90 and some change or 91 area. It's generally right on the mark at 90 or above. So just think about that when you're looking at the test. But above 92 is where you're going to think about with this. And just so we have some terminology down accurate here, when you're above 92, it is not an anemia. Okay, so don't say it's a macrocytic anemia. That's not what you've got. You've got a functional macrocytosis. You're looking ahead of time and saying that those cells are too large at this point. So you're seeing a problematic picture begin to manifest, but really those cells need to be, or that size of that needs to be greater than 100. You could probably fudge that down to about 98 depending on some of the labs out there, but really greater than 100 is where you're going to be at before you start truly labeling that. And then when you get to above 92, definitely consider your B12 and your folate supplementation. And then the other marker you can look at to confirm this with is going to be your RDW, that red cell distribution, right? Now, what you're going to see too is if you're running some of these additional markers I'm getting ready to go over concurrently, the blood count, the homocysteine, you're going to see that these markers start matching up pretty good when you start using some of these functional values. Usually when the homocysteine's out of range, your MCV is going to be out of range as well. But now that you guys look at this and you see those numbers, you actually have a visual representation to make an association with that of actually what it is that's taking place and why that number is not any lower than it should be, why it's not down closer to 90. Now let's talk about homocysteine again. Let's just kind of revisit this real quickly here. Again, homocysteine has got to go to methionine, or it's got to go down into cystathionine and ultimately glutathione down here. But this is our step. This is where we're going to see problems start to manifest. And it's generally this portion of the pathway that becomes blocked, and this enzyme is not as functional as it needs to be, that causes homocysteine levels to elevate. It can be transitioning homocysteine down to glutathione, but this is not as problematic of a portion of the pathway as looking at the methionine synthetase. And here's just a simplified diagram for you. I mean, this is really cutting out all the additional verbiage on that previous slide. Now, let me make some associations here for you. This homocysteine is correlated inversely with folate and vitamin B12. Now, let me show you one thing. If you guys start going and looking at this, you're also going to notice that in these studies they talk about this S-adenosine homocysteine here. If I go back to this, notice in this pathway, the only portion of this pathway that's bidirectional is this S-adenosine homocysteine right here, right? So some of these studies will say that S-adenosine homocysteine is related to, or is inversely related to B12 and folate, or homocysteine is inversely related to B12 and folate. It doesn't matter. It's bidirectional here. It's just going to interchange back and forth between itself, right? The bottom line is that an elevation in either one of those is an increased need for B12 and folate. The other thing is, I don't know anybody that tests this commercially. So for us as clinicians, it's kind of irrelevant, right? So homocysteine is what we're really looking at. But bottom line is, here's a study that is giving you a direct correlation between the two. And just to really drive home that point a little bit more, and I just grabbed a few studies here. There's tons of these out there. But you'll notice here's 4 more studies that are saying the exact same thing, that there is a definitive correlation between homocysteine and B12 levels, right? And think about this too. Homocysteine, even though this has been around for a long time, right? It was discovered decades ago, literally by Kilmer McCulley. But when he looked at this, they really didn't know the implications of this. And now that this has come online, and now that we have a better understanding of it, there's so much of a public health problem with B12, it makes sense that you're seeing an emergence of research in both of these parallel each other. Some of the general levels you're looking at with this are going to be, for cardiovascular protection, you're looking at less than 15. But if you really want to get into adequate methylation and adequate neurological protection, under 7 is where you got to be on this. And the under 7 is the number that's going to correlate with that MCV on the CBC.
Say that again.
The
very last thing you said.
Yeah, your homocysteine levels less than 7 are what are going to correlate with the MCV levels that are less than 92.
Okay.
So if the homocysteine is greater than 7, you're likely to see a MCV level that is greater than 92.
Greater than or less than?
Greater than. Just as a sidebar here, because it's good clinical information, if you happen to see a homocysteine level that's up greater than 15, it's probably not B12 by itself. Mm-hmm. Go look at the folate levels. You may, and actually with these, if I see them greater than 15, actually a lot of times if I see them greater than 13, I'll just run the MTFHR genetic testing, and a lot of these people will have that. Now, let's talk about your white blood cells. We talked about red blood cells. Now let's talk about our white blood cells for a minute. Now, what's the main difference between, from a structural perspective, what's the main difference between a red blood cell and a white blood cell? What did the red blood cell kick out? The nucleus, right? What does a white blood cell hang on to? It's nucleus, right? So that is the reason, that one point right there is the reason that you can look at a static test, like a traditional static test, such as a CBC, and get clinically relevant information, because those red blood cells, whatever you pick up at the time you've done that test, that's what they've done, right? Mm-hmm. Versus a functional assessment like this, where you're still looking at living tissue because you've got that nucleus that's still active. Mm-hmm. Right? You guys see that differentiation there? Okay. So, and if you've got a nucleus that's active, it's got to be able to carry out its role. It's got to be able to replicate DNA to just be able to do what it does on a daily basis, right? So to carry out that process of DNA replication, you've got to have adequate B12 available to do that. Again, this is going back to that process of methylation. If you can't methylate, you can't replicate the DNA, you can't continue to produce healthy white blood cells, healthy lymphocytes here. And actually you can just kind of look at some of these white blood cells, and you can see how large these nuclei are in here. And then this is just cytoplasm out here on that side. And actually, a good point of differentiation here is that these are in the background. These are going to be your red blood cells, and the way you know that is that red blood cells are biconcave, right? They have kind of this shape. Well, that looks like a donut to me, right? So same thing. So these are red blood cells. You don't see the nuclei staining here. These are going to be your lymphocytes. You're looking at the nuclei staining on these slides. You got a question?
I was going to ask you to say again the comparison with the static test and what is the other test?
The functional test. You just need a differentiation between those two?
Yeah.
Okay, a static test is going to be a traditional chemistry where whatever you draw at the time you did phlebotomy, that's what it is. That's what the status of it is. But it doesn't necessarily reflect what the overall health of an individual is. It doesn't give you a window into what the biochemical function of that individual is on a day-to-day basis, right? The functional testing is going to give you a longer window of application. So for example, with the micronutrient testing, we're looking at roughly about a 4 to 6 month window on that. So it's just a longer time frame.
How do you accomplish that longer time frame then?
You're looking at living tissue is what the difference is. The best example I can give you literally is the difference between the red and the white blood cells. When you pull a red blood cell, it's not a cell that's out there continually replicating. It's being produced from the bone marrow, right? So once it's maturated to what it's going to maturate to, it's not really changing that much. I mean, you might get some influences on it through like glucose and changing the hemoglobin A1C and things like that with it, but the actual development of that red blood cell has not changed. That's not the case with these white blood cells. Because they have a nuclei, they're still changing and adapting to their environment. They're actually living tissue. So when the lab cultures these out, when they do a blood sample and it goes to the lab and they culture these out, they're literally continuing to grow these white blood cells to see how they're adopting or how they're adapting to a change in nutrient levels, whether it's B12 or folate or glutamine or whatever the nutrient that they require for function is.
Is that what you're saying you're looking at over this longer time period?
Yes.
Okay.
Yes, that's exactly right. So again, we always want to have some validation for what we're talking about here, and just to kind of emphasize this, we're looking at the top of the slide, DNA methylation in white blood cells. So clearly this is an event that takes place. But the highlighted section here, data on whether DNA methylation changes in white blood cells can serve as a useful biomarker for different health outcomes. Right? So we know that this is an important process. But look at that. And it's saying right now, this is something else that's very interesting. It says that it's limited at this point, but it's rapidly emerging. So again, this is another body of literature that's taking off right now, really studying this DNA methylation process in these lymphocytes. And of course, most of us in here know that the lab of choice for that is going to be SpectraCell here. Now, methylmalonic acid. Methylmalonic acid is a test you can order from LabCorp, you can order it from Quest. Most of your larger commercial labs are going to have this test available. You can do it in urine, you can do it in serum. You might get some differences in which method is preferred. I don't really think it matters that much. Bottom line is, what is this assessing? So if you look at just normal metabolism, taking your some of your branched chain amino acids up here and moving them through fatty acid metabolism, taking them through different metabolites, you get into this methylmalonyl-CoA. And to get to succinyl-CoA, you've got to have an enzyme, methylmalonyl mutase, or methylmalonyl-CoA mutase here. That is a B12 dependent enzyme. So that's where you're looking at that B12 has to take place, or where that B12 has a role at. If there's not adequate B12 to run that enzyme, then you get a buildup of methylmalonic acid. So literally you're just backing up that metabolic pathway. And what starts happening, you start spilling off those metabolites. Now, here's the standard right now out in healthcare. It's going to be your serum B12 levels. But I want to point out a couple of things to you on why we need to look past serum B12. And really, as I'm going through this, and you guys are having dialogue exchange either with patients, with other practitioners, this body of literature behind this slide is really going to be some of the evidence for you to be able to say, you know what, let's maybe take a look at some of these other methods of assessment, because there might be some problems with B12 here. So let's take a look at this. What is it that you're really looking at when you're looking at B12? So you're looking at the amount of circulating B12 at the time you're taking the test. So it's really looking at, you did that blood draw, it was what was in the serum, per that amount of volume of blood that they looked at, and that's about the extent of what that definitively tells you. It doesn't tell you much more than that. Even looking in the serum, there's some different testing methods that we have that even if you just wanted to stay in the serum and not look at anything that we've looked at up to this point, it'll still show you that serum B12 is not the best marker to use to assess B12 status. So there's no real window into the past here. And it doesn't look at methylation because you're not looking at a living tissue when you're looking at that B12. There's really no incorporation of that into any cell in the body anywhere to truly say what that B12 is doing for it. It's just there. And just to kind of tell you, or just kind of give you a time frame of how long people have been out there going, is this really the right way to look at doing this? This study was from 1979. So for over 30 years now, we've been in the research questioning whether or not serum B12 is the right path to take. So from practical neurology, here's what this says, is that we describe a case of functional B12 deficiency where repeated measurement of serum B12 levels within the normal range led to a delay in the diagnosis of subacute combined degeneration of the spinal cord. That's pretty serious, right? So I want to know about it before my spinal cord starts degenerating. And then this is a more recent study out of the American Family Physician. And I thought that this was pretty good. And I'm actually going to take the time to go through this with you because I think there's some highlights in here that I want to point out. So B12 deficiency is common in megaloblastic anemia. Okay, so now we've got admission in a study that you can look at a CBC, the MCV, and actually pick up whether or not you should be thinking about B12 supplementation here. So we've got an acknowledgement of that. A variety of neuropsychiatric symptoms. Let's be honest, how many of our patients come in, or what percentage of our population comes in and has some degree of admitted neuropsychiatric concerns? A large percentage, right? A large percentage. We're kind of laughing about that, but I don't say that. That's why I said admittedly. They're coming to us saying this. Not that we have to really be the investigator here and uncover it and dig it out of them. They're admitting this to us. And elevated serum homocysteine levels. Okay, we know that those are elevated in a large percentage of the population, and especially in older persons. Okay, again, a growing portion of the population here. There are a number of risk factors for vitamin B12 deficiency, including prolonged use of metformin. How many patients are on metformin? Our last lecture was on looking at dysglycemia, and we talked about just some of the sheer numbers of how large of the percentage of the population is that has some type of dysglycemic presentation. So, you know, there's a role for metformin there, and the proton pump inhibitors. Those are given out like candy, right? And the standard usage of stay on them for 2 weeks, we know that those are stayed on for much greater than 2 weeks, right? So we've got a large percentage of the population that is at risk for this. No major medical organizations. Let me go to the next one here. Measurements of serum vitamin B12 may not reliably detect deficiency, and measurement of serum homocysteine and or methylmalonic acid should be used to confirm deficiency in asymptomatic high-risk patients with normal levels of vitamin B12 or normal levels of serum B12. So basically what that says alone by itself is you can't depend on serum B12 levels, period. End of story, right? Now, I'm going to talk more about this next point in a little bit, but I want to go ahead and plant the seed for you on this. Oral administration of high-dose vitamin B12 is as effective as intramuscular administration in correcting the deficiency regardless of etiology. Now, let me make a point here that when they talk about etiology as it's used right here, they're talking about those etiologies on the previous slide that they identified, all right? What I'm going to show you is what are the etiologies that you do need to think about intramuscular B12, because there is a role for it. But again, this does drive home the point that oral administration is effective. So you can get it done with oral B12. And clinically we see that, right? We correct those B12 deficiencies in a lot of our patients. So we know we can do it. So here's your takeaway point from those previous slides. Serum B12 only assesses B12 being mobilized at the time of phlebotomy. It does not assess any aspect of methylation directly. So again, you're not looking at a functional process here. And again, no direct physiological function. Now, here's a couple of markers that are out there. These are not commercially available to us, but I think again, it does drive the point home that if researchers are out there still looking for different ways to assess B12, it really does signify that there's a problem with traditional methods of assessment with this. So this deoxyuridine suppression test, you guys remember uridine, thiamine, some of these different molecules here, they're all involved in DNA replication. Remember that, DNA and RNA, where you get the C's and the T's and the G's and the A's and all that stuff? Okay, that's actually what this is starting to look at. This halotranscobalamin, this is a cobalamin-saturated transcobalamin, right? So basically, what this is saying is that transcobalamin is the carrier protein in the body for B12, and if you've got a cobalamin saturated, it's just you've got B12 bound to that protein. That's more or less what you're looking at here. Good test. I'll show you a limitation to them coming up. You've actually got a halotranscobalamin 2, which looks at your active B12. And then I thought this was pretty interesting. I wasn't aware of this. There are actually B12 breath tests out there. So pretty interesting, right? You can go back and read some of this stuff, but that's what it's actually, this is the exchange or the process that it's involved in and it's looking at. But again, to my point, if B12 serum levels were actually adequate, why would everybody be chasing this stuff down to try to figure out a different way to look at B12? So here's a study looking at the halotranscobalamin and methylmalonic acid. But the use of those two enable us to differentiate between storage depletion and functional vitamin B12 deficiency. Okay, so this is to some degree the same type of conversation we had last time when we looked at intracellular vitamin D levels and serum vitamin D levels. So what we're looking at is that intracellular is actually in the cell, it's being utilized on that day-to-day basis, but the serum vitamin D is what's in reserve. It's what's sitting behind for us to pull from should we need to do that. More or less, that's what this study is differentiating also for vitamin B12. It's saying that serum B12 it's good to know that you've got high levels of serum B12 and that it's sitting back there in reserve, but it really doesn't tell you how B12 is being utilized and incorporated into cellular tissue on a day-to-day basis. That's what markers like this halotranscobalamin, methylmalonic acid, and honestly, just about every one of these previous markers that we've looked at also say that. Here's another study. Compared to total cobalamin, we observed a better performance out of halotranscobalamin in detecting elevated concentrations of. The point that I wanted to make on this is that you can actually get good measurement out of the methylmalonic acid and the halotranscobalamin, pretty much with the exception of renal patients. So if you've got a patient that's got some type of renal issue, these two markers probably aren't the best options to start looking at. But what do we have to pull from? We can look at homocysteine, we can look at the size of those red blood cells, we can look at the lymphocyte levels of B12 to really determine this. And here's a diagram to differentiate those for you. I've got a reference down there for you if you guys want to go back and pull this. This is actually a kind of neat study. But what this is looking at, let me kind of put some detail in here for you. What you're going to see is that that's your halotranscobalamin. So that's your carrier protein. The little dot in the middle down here, that's your B12. So what you're seeing is that the combination of those two gets carried up to the cell. But here's the important point about this. You've got to have an active receptor in here to be able to take take that B12 up to incorporate it into these different cycles that we've talked about, these different intracellular cycles. So now you can look at this and say, well, if I've got an increase in methylmalonic acid intracellularly, I know that this is not taking place. If I've got an increase in homocysteine intracellularly, I know that this is not taking place. So the difference, my point being, is that these are still looking at an extracellular component. So while this is certainly a better marker than serum B12, it still has some issues with it, right? We want to be in the cell looking at living tissue. And the methylmalonic acid, your total homocysteine, and your lymphocyte proliferation of B12 are actually going to be able to answer that question for you. This is just a more complex diagram, kind of looking at the same types of things here. But the point being is that all these processes, when you guys see these mitochondrial lysosomes, it's all intracellular, right? It's all happening inside of the cell. Again, if you want to look at these in more detail, those references are there for you. Okay. Does anybody have any questions to this point? Okay, good. Let's look at a few case studies here. So this is a 55-year-old male with a history of DVTs and hypertension. Both parents died of some type of neurodegeneration. And again, what did we say earlier? Homocysteines greater than 7 have been correlated with neurodegeneration. History of colon polyps, potential DNA methylation problems here. Right? Routinely consumes grains. So we know that increases in grain causes an increase in inflammatory presentations in the gut. You decrease absorption, malabsorptive state, so your B12 levels are going to decrease, right? So he's at risk for this. And then additional abnormal lab findings. As a male, he had elevated estrogens and elevated triglycerides. So elevated estrogens, potential detox problems here again. Phase 2 detox, one of those 6 subsets of phase 2 detox is going to be methylation. So again, we're potentially seeing issues with his ability to clear those out. So what did his labs tell us? Well, if we go back and look at the CBC, and I've just kind of extracted these out so from a functional viewpoint so you guys can see him. His MCV is at roughly 95 here, and this MCH is closely mimicking that. But again, the target point here is that it's above 92. Correct. Thank you. Looking at his micronutrient assessment, you'll see that he actually had a B12 deficiency here. And ironically enough, I put folate in here for the reason that if you look at the newer reports, this was before they started using those, somewhere along right there would be about where the functional line for a marginal deficiency would be. So he's marginally deficient for folate as well in his presentation, but he's overtly B12 deficient. And then homocysteine down here at a 15.6. So he's basically got the entire sequela here. He's got just about every one of those markers we talked about. And I make this point to show you that these markers correlate with each other. This is not the exception to the typical presentation. This is more or less the rule of what you're going to see. Your case 2. Celiac disease, confirmed celiac disease with biopsy and some of your more traditional lab markers here, and he had a presentation of psoriasis, so he's got active autoimmunity. Has made some dietary changes. His father has Sjogren's syndrome, so again, now we got a family history of autoimmunity in here. He's starting to notice some memory loss and apathy. Okay, so two things with this. The memory loss, you could again go back and think about the neurodegeneration, but also very early on we talked about looking at B12 as a methyl donor. Well, if you look at some of the interconversions between these neurotransmitter intermediates, you got to have methyl donors to be able to carry those processes forward. So you could be looking at some of that here on those dopamine pathways. He gets tired after eating, so potentially some blood sugar considerations here. And again, if you think about this, you know, and this guy, just to kind of give you an overall presentation with this guy, he was kind of a big guy. I mean, not like heavy, a lot of adipose tissue. I mean, he was just a big guy. He was an ex-football player. So, you know, big, muscular type of guy. But his diet had really fallen off. He was eating a lot of carbohydrates, was really just kind of getting some protein in there, you know, where he could, but he wasn't really doing a more traditional paleo type of diet. He was going more standard American pathway of diet. Hamburgers, high carbs, French fries, all that stuff. So that correlates with not having as much, it correlates with two things. One, not having as much protein intake, and we know that B12 is going to be found predominantly in animal-based protein sources, so there's one consideration. And then two, if he's got a higher grain intake, potentially he's creating, again, that increased malabsorptive state in the gut. Right? So two things to think about there. And then his additional lab findings, he also had elevated estrogens and androgens for him and an elevated insulin level. And there's just some pictures of his psoriatic presentation.